Hello, I'm Dr. Marla Shapiro, and today I'm joined by Professor Fauser from the Netherlands, and we're going to be talking about PCOS. Firstly, can you introduce yourself and tell us a little bit about your work?
Hello, good day, dear colleagues. My name is Professor Bart Fauser. I'm from the Netherlands. I'm a professor emeritus in obstetrics and gynecology. My focus has been mainly on women during reproductive lifespan, but more and more around PCOS, but also around other ovulatory dysfunction conditions. We and many others and many other professionals are looking into potential long-term health implications, which is going to be the topic for today's discussion.
So let's focus on PCOS. We know that it's prevalent, but often it's not diagnosed. So firstly, let's talk about your advice on how we would diagnose PCOS.
Yeah, the diagnosis of PCOS, let's start with a statement that it's a polycystic ovary syndrome. It's a syndrome which is not a single gene, single symptom condition like other disease conditions. So it is heterogeneous by definition. For about 20 years now, what is globally accepted, maybe with some minor exceptions, is that the Rotterdam criteria are generally used to diagnose PCOS. And this is based on a consensus meeting which I organized in Rotterdam, where I used to work. And this has been, at that time, goes back to 2003, has been replacing the 1991 NIH criteria. And this Rotterdam criteria has later on been embraced by NIH. And it means, or this goes back to three key hallmarks relevant for the diagnosis of PCOS: the polycystic ovaries, or the polycystic appearance of ovaries, originally based on ultrasound, but now more and more also diagnosed by a ovarian hormone, AMH, anti-Mullerian hormone. This next to hyperandrogenemia, so elevated signs, biochemical or clinical, of elevated androgen levels or exposure, and thirdly, irregular periods, amenorrhea or oligomenorrhea, so also related to ovarian dysfunction.
Okay, so let's talk about the long-term health implications of having PCOS.
Yes, this is a topic which gained increasing interest, and it still is over the last 2 decades. The primary focus in healthcare on PCOS was by gynecologists faced on short-term problems like irregular menstrual cycles and associated infertility. So this was just the short-term focus. Now more and more there is interest from diabetologists, internal medicine, metabolic, vascular medicine, cardiology, geriatry, focusing on long-term health implications of this prevalent condition. 10, 15, in some areas in the world, 20% of all women can be diagnosed with this condition. So there's increasing interest, but the data are not so very clear. Overall, and the meta-analysis that are being performed showed a slight increase in long-term health risks.
So if we look at the evidence for those long-term health concerns, what is the evidence like, and what specifically are we concerned about?
Yeah. The evidence, there's going to be an updated global PCOS guidelines going to be released very soon. And there it is stated that there is a significant but modest increase in several outcomes, outcomes like myocardial infarction, outcomes like stroke, and outcomes like longevity. But again, this is still a matter of debate, and still there are quite some studies that are unable to demonstrate such a difference. But overall, again, and based on consensus and meta-analysis where all published studies are included, the general consensus is that there is an increased risk.
So are there specific risk factors that we should be looking at that really are important for these long-term health concerns? Because these are significant long-term health concerns.
Yes, there are specific risk factors which are not so very different from the general population. Obesity is a clear risk factor. Insulin resistance and later on type 2 diabetes is a clear risk factor. Again, those two are common in the general population. What is not so common is that in metabolic dysfunction at a younger age and later life health risks are clearly associated with hyperandrogenemia. So there is a close association between elevated androgen concentration in these women and increased cardiometabolic risk at later life.
So it's interesting that I don't think we can focus that much on primary prevention as much as we're really focusing on secondary prevention of these conditions that you're talking about. So when we talk about secondary prevention, and really you talk about really a global span of physicians in multi-differential healthcare specialties that this is impacting on, what should we be focusing on?
Yeah, I think at this stage, some reservation is needed. It is interesting when you look at, there are different global organizations, associations that focus on this, the European Endocrine Society, the American Endocrine Society, some OBGYN societies, and organizations like the IMS, and they all come with different recommendations, which for me makes it very clear that we do not really know. What is recommended is more frequent checkups of women at risk. But what this more frequent means is not really well defined. Does that mean yearly, once every 2 years, once every 5 years? Should we do this in all women with PCOS or only in a subgroup at increased risk, as we mentioned, especially the obese, insulin-resistant, hyperandrogenic? And then what do you assess, yearly or every 2 years? All the metabolic dysfunction parameters, OGTT, of course, blood pressure. So when you compare the recommendations of the different professional organizations, there's not one identical. They're all slightly or more distinctly different. So for me, that means we don't really know.
Now, here's an interesting question in terms of women with PCOS who do go on to have children. Are there implications for their offspring?
Yeah, that's another controversial issue. Also, it's not so easy to study. We can go into the details later. We've been working on this. It's not surprising when you think about it. In the earlier days, infertility in PCOS has been a big issue in OBGYN. Ovulation induction, now more and more ovarian stimulation in the context of ART. In the earlier days, the biggest problem during pregnancies in PCOS was multiple pregnancies. A very significant proportion of pregnancies induced in PCOS were multiples, with all the associated problems. Now, that to a large extent has been solved, that problem. So now also medically induced pregnancies are almost all singleton pregnancies. And now it becomes obvious, and when you think about it, not so surprising, these pregnancies are more often complicated, particularly, there you see it again, in obese women with PCOS, in the hyperandrogenic women with PCOS, and with the women with signs of metabolic dysfunction. And again, that cannot be a big surprise, when you think about this. So yes, it is clear that there are more pregnancy complications and more suboptimal perinatal outcomes. But now, and again, not surprising maybe, it becomes clear that these women, that these children born from women with PCOS, they have more often signs of metabolic dysfunction, even at an early age. And then for me, it has always been the question, is this related to a genetic predisposition? Is it a gene? Or is it environment? Is it abnormalities during fetal development that induces these changes? And of course, the first thing, the genetics, yeah, that's a damage done situation. So there's not much you can maneuver there. But if it's the embryonic environment, of course, there is a lot we can do in terms of hyperinsulinemia during pregnancy. There's more often preeclampsia during pregnancy. So those are factors that can be modified and influenced.
Right. Is there a male phenotype of PCOS? Well, we're talking about offspring. What about males?
Yeah, of course, when you talk about cycle abnormalities and ovarian dysfunction, that's not going to work in the male.
Yeah.
But clearly, the signs of metabolic dysfunction, and it's not so well studied. There are some publications, but they suggest that metabolic dysfunction is as prevalent in male compared to female offspring of women with PCOS. So the metabolic phenotype and the metabolic abnormalities apparently it is also clear in the male. And it brings again, is that genetic or is that embryonic development abnormalities?
Yeah, so the last question before I let you go from this fascinating conversation is whether or not we think this is an inherited disease.
It's already known for a long, long time that PCOS runs in families.
Yes.
It's not a single gene condition, of course, so therefore the mode of inheritance is not so very clear. But now with big sample size GWAS studies looking at SNPs and distribution, a greater proportion of how it's inherited becomes clear based on these SNP analysis. And this is only recent knowledge based on meta-analysis of over 20,000 women who undergone a GWAS analysis. So yes, there is a genetic component to it, but it doesn't listen to classical genetics.
Yeah, it doesn't sound like there's anything classical about this disease. Thank you so much for joining us today. It's a fascinating topic. Clearly, new evidence emerging, new guidelines for us to watch out for. We'll look forward to having you back.